Hi guys, good evening. Can you all see me? Can you all hear me? Alright, so good evening, good evening. So we'll start from where we left off yesterday. Yesterday it was a bit eventful day. While I was in the lecture, I suddenly got a call from the ICU. We had one of the patients who were getting arrested. So we had to run, and hopefully, we did well. The patient is still alive. But then this patient has been there for a week now. It's quite difficult. So still in the same context. So BLS series के notes update कर दीजिए. But BLS series के notes have been put up in the Telegram group also. It is there on our official Medit group also. I'll ask them to pin the complete notes again today. ठीक है? So welcome Mansoor. Hi Osama. Good evening Rahul. Good evening Bad Doctor as well. So we'll start from where we left off yesterday. So yesterday we spoke about the Graves' disease, right? So we told about that what is a basic Graves' disease is, that is a diffuse toxic goiter. It's an autoimmune disorder. Now, because it's an autoimmune disorder, it will have an antibody. The antibody goes by the name is called as a long-acting thyroid stimulating antibody. This antibody mimics the TSH hormone, so hence binds to the receptor. Because it binds to the receptor, there is excessive release of T3, T4 because of overstimulation. At the same time, because of excessive stimulus that is going to be given to the thyroid follicle, they also start to proliferate. Hence, uniformly they develop into a hyperplastic gland, and that is what we call it as diffuse toxic goiter, right? So we spoke about how are they going to present to you. So Graves has both the thyroid and the extra thyroid manifestations. Now, this is on examination that you would have found that the gland is going to have a smooth surface. Usually it is because there's a good increased vascularity is noticed. Graves predominantly will have a CNS symptoms. They'll also have fine tremors and brisk, deep tendon reflux. Now, until this point, we all know what is the Graves disease going to bring it for you. Now, how would you like to evaluate? Any patient who has presented to us with a thyroid swelling, right? So in terms of investigation, I want to know what it is. The first is going to be the thyroid function test. In the thyroid function test, I'll be looking at the T3, I'll be looking at the T4, I'll be looking at the TSH level, right? So in the Graves disease, what is going to happen? Because of excessive stimulus of the thyroid follicles, you see T3, T4 will be elevated, and because of the negative feedback, you see the TSH will drop. Here the TSH drops because of negative feedback. But why there is excessive T3, T4 release? The excessive T3, T4 release is because of your antibodies which are mimicking like your thyroid hormone, right? Now, once we know the patient is having a hyperthyroid status, there is no role for cytology, but I would definitely like to do an ultrasound, and the ultrasound is going to tell me whether it is a uniform or a nodular status of the gland that is available. Now, once you have done the ultrasound, the third investigation that you can do is a radioactive iodine scan. The isotope used is going to be iodine 123. Now, all these radioactive isotopes, whenever you administer, you are going to administer via the oral route. You will administer this as oral route as well. Iodine 123, what is the T half? The T half of this, in iodine 123, remember, remove 2, you get 13 hours. And what is the radiation that it emits? It emits the gamma rays, which are going to be helpful in diagnosing the lesion. As simple as that. So we give it via the oral route. You look at for the T half is going to be 13 hours, and the route of the radiation that it emits is going to be of your gamma rays. So whenever we give a radioactive iodine, I'll be assessing the status of the gland or the status of the nodule that is going to be present. So in order to understand better, let's say this is the thyroid gland, and these are the thyroid follicles that are present. These are the thyroid follicles that are present. When you give a radioactive iodine, this radioactive iodine is nothing but a iodine which is having now labeled with a radioactive isotope. So what it happens is, in a gamma camera, it gets illuminated. So you see that whenever the iodine goes into the thyroid follicle, this will also go, and you will see the thyroid follicles will get illuminated, and that can be picked up on gamma camera. So I can know the uptake in the thyroid follicle. Basically tells you how much uptake is there. Imagine that there are 3 sites, or I can say there are 3 nodules which are going to be formed here, right? In all these 3 nodules, the uptake is going to be in this particular form. So based upon how much uptake is there, I can give you the name of individual nodule that you can see across here. Now, if you see the first nodule that I've displayed in front of you, it has got the same uptake as that of the surrounding follicles. So this will be called as the warm site or a warm nodule. This nodule has a more uptake than the surrounding follicles. This is what we call it as hot nodule. This indicates overactivity. This indicates the overactivity. Now, this is what we call it as the cold nodules. So cold nodules is having a lesser activity when compared to surrounding. Remember, it is the cold nodule, if present, is suspicious of malignancy. So my objective is to look for whether a particular thyroid scan, does it have a cold nodule or not. Okay. Now, if it has got a cold nodule, I should be extremely careful, because cold nodule is basically suggesting that it could be a malignant lesion. Okay. So here, because we are looking at an excessive secretion, an over secretion basically indicates that it is a hot nodule. Over secretion indicates it is a hot nodule. So Graves is going to be overactivity, more follicles, more uptake and more proliferation. So hence you'll have a more, excessive uptake will be there, which will be called as a hot uptake. Okay. Now, once you have gotten the patient with the component that you have the radioactive iodine, now I have 2 things in, I have 3 things in my kitty right now. I have a patient who's having a hyperthyroid. It's a uniformly enlarged gland, and the radioactive iodine says there is a hot uptake. That means an excessive uptake has been present. This gives me a diagnosis of Graves. The last nail in the coffin is going to be the antibody titer. Now, in the antibody titer, I will look for the LATS antibody, and you will see the LATS antibodies will be elevated in these particular patients, right? Does Graves swelling have more complication than the other swellings? See, we are not talking about Graves swelling per se. It is a uniform swelling. It is going, from a swelling perspective, it will have the same presentation as any other goiter. But because it's a toxic swelling, it is slightly difficult for us to manage. And remember, this is going to have more vascularity. So intraoperatively, this will be more challenging as well. Is that clear? Okay? Chalo. So once you have a diagnosis, now I have a working diagnosis of a Graves disease. So how do you manage? So in the management, we have a phase-wise management, right? So in the management, the first line that you will do, this patient is a hyperthyroid patient. I'll never operate on a hyperthyroid patient because it is a hyperdynamic circulatory status. If I operate, it will bleed more, it will cause more complications. Excessive release of hormone can also trigger arrhythmias. Tachyarrhythmias are the most common, that is atrial fibrillations are one of the most common arrhythmias that you will see in a patient of toxicosis. Warm nodules means normal. Nahi beta, warm nodules means overactive nodules. They are more active than the surrounding nodules. They have more follicular cells. They are more proliferating. They are hyperactive. And one of these hyperactive status will result in what? Excessive hormone secretion. So you have the examples like Graves. We'll talk about the multinodular goitre, which is toxic. We'll talk about toxic adenoma. All these are overactive nodules. Okay. Now, in the first line of the management, what are we going to do? In the first line, I'm going to start the patient on anti-thyroid drugs. I'm going to talk about the anti-thyroid drugs. So all my second year bachas and the third year bachas, I mean, you can, any kid who is above second year and from there onwards, can you tell me what are the anti-thyroid drugs we have? What are the anti-thyroid drugs we have? So, in order to understand this, we'll again take a very classical approach for us to understand. So let's say this is your thyroid follicle, right? This happens to be your sodium iodine symporter, which is going to bring the iodine into the follicles, and from there you know what is going to happen. The T3, T4 is going to be formed. Once the T3, T4 is formed, the T3, T4 will be released into the systemic circulation. This will release of T3, T4 into the systemic circulation. From here, it will go into every nook and corner of the body, but whenever they require excessive amount of hormone, whenever the requirement for the hormone is going to increase, what is going to happen? You will now notice that the T4 is going to get converted into T3, that is your peripheral conversion. This is what we know. Now, what are the drugs and where are they going to act? The first drug that we have is your sodium iodine symporter. Example like perchlorate. Example like perchlorate and thiocyanate. Right? These are the two drugs which we have. Both of them are extremely toxic. They have more side effects. Since they are withdrawn out of the market, we do not have these drugs available. But if you remember this word thiocyanate, did we use this thiocyanate anywhere? Did we see this thiocyanate anywhere? We did see. It is our Brassicaceae family members who produces the same compound, that is thiocyanate, and that thiocyanate is going to cause the blockage of sodium iodine symporter. No, so iodine is not being able to take up, so that is why the patient is developing hypothyroid there. You remember, so that is your same thiocyanate, but then too toxic, can't control. If you can't control, you can't keep it, dump it across. Then you have the drugs that inhibit the T3, T4 release. These are the thyroid constipating drugs that you have. We have the sodium iodide, the potassium iodide, as well as the Lugol's iodine. These are going to be the Lugol's iodine. In between that, you have the drug that can inhibit the thyroperoxidase enzyme. These are the TPO enzymes that you have. These are your thyroperoxidase enzymes which are present. Drug that inhibit. So I will say this is going to be the class 3. So we'll take this as the class 2 drugs. Drugs that inhibit the thyroperoxidase enzyme. Drugs that are going to inhibit the thyroperoxidase enzyme. Now, drugs that inhibit the thyroperoxidase enzyme, these are your Carbimazole. These are your Carbimazole and propyl thiouracil. These are your Carbimazole and propyl thiouracil. And the third set of drugs that we have is the thyroid constipating drugs, not allowing the hormone to secrete, that is sodium iodide, potassium iodide, and Lugol's iodine. And the last set of drugs that you have, which is going to inhibit the peripheral conversion. Now, drugs that inhibit the peripheral conversion, number 1 is going to be prednisolone. It's a steroid. Then you have propranolol. And you have our propyl thiouracil. It is your propyl thiouracil, right? So these are the anti-thyroid drugs. Rather than trying to remember them as one single drug, I have given you the entire mechanism of action, that how are we going to use these drugs. So each and every important mechanism is going to be mentioned across here. Now, what are the points to be remembered in terms of the thyroid drugs? Now, the points that you have to remember from the thyroid drug perspective, number 1, which is safe in pregnancy. Which anti-thyroid drug is safe in pregnancy? The answer is propyl thiouracil. It is going to be the propyl thiouracil. Which anti-thyroid drug decreases the vascularity of the gland? Which is the one which is going to decrease the vascularity of gland? The vascularity of the gland is reduced with the help of the Lugol's iodine. Lugol's iodine decreases the vascularity of the gland. So obviously in Graves' disease, I will give patient a Lugol's iodine, right? Now, if they ask you what is the protocol of giving a Carbimazole? What is the protocol of giving a Carbimazole? The current protocol of giving the Carbimazole that we follow, we give around 30 to 40 milligrams per day. This is the maximum dosage that you can give. Now, how long does it take for the patient to become euthyroid? Remember, when you start the patient on Carbimazole, it takes approximately 8 to 12 weeks. It takes patient around 8 to 12 weeks to become euthyroid. It takes around 8 to 12 weeks for a patient to become euthyroid after you have started a Carbimazole. after you have started the Carbimazole, right? Okay, so Rahul says, sir, what's the difference between the hot and the warm nodule? Warm is isoactive. That means whatever is the activity of the surrounding follicles is the same activity that you see in the nodule, then it will be called as warm. But if it is more than the surrounding, it is hot. If it is less than the surrounding, it is cold. It's as simple as that. Okay? So you give Carbimazole at 30 to 40 milligrams per day, and then within 8 to 12 weeks, the patient is going to become euthyroid, right? Now, once the patient becomes euthyroid, there is something called as maintenance. We will not stop it because again it will jump back to hyperthyroid. So let's say the patient has become euthyroid in 8 to 12 weeks and patient does not want to get operated immediately. So during that phase till he gets operated or she gets operated, the maintenance dose is going to be 5 milligrams. It is going to be given 5 milligrams every 8 hourly. So doses that we give is 5 milligrams every 8 hourly. So that is nothing but 5 milligrams 3 times a day. It is TID dose, right? We give 5 milligrams 3 times a day, right? So this is with respect to the anti-thyroid protocol. Now one more important thing is, let's say a patient goes into hypothyroid state, because you're giving anti-thyroid drug, no, it suppresses the higher hormone secretion. They can go into hypothyroid also. So to prevent hypothyroidism, due to Carbimazole, in the maintenance phase, I will give 0.1 to 0.15 milligrams of thyroxine daily. That should be administered on a daily basis. See? So these are the components from a drug perspective that you should be aware of. Okay. Now once you made the patient euthyroid, you have followed all this protocol, the patient is absolutely fine. Now comes the second line management. The first line management was to make the patient make a euthyroid. So anti-thyroid drugs, it is to make patients euthyroid, prior to surgery. That is in fact the most important prerequisite in operating a patient in a hyperthyroid status. Now once the patient is euthyroid, the second line component is going to be an intervention, right? So this becomes the how do you intervene is dependent upon the age of presentation. If you have a patient age less than 45 years, or if the patient is age more than 45 years. Age less than 45 years, I'll go with surgery, and currently the preferred surgery is going to be total thyroidectomy. We'll remove the entire gland. If the patient is more than 45 years, then I would prefer a radioactive iodine. And when we talk about the radioactive iodine, in the radioactive iodine, we are going to give iodine 131. We're going to give iodine 131. So what do you think the iodine 131's half-life is? Quick feedback. Right, so what do you think the iodine 131's half-life is? Quick feedback. Very good, guys. Very good. The iodine 131 half-life is going to be 8 days. It is an 8 days. Again, the route of administration for iodine 131 is going to be the oral route. It is going to be the oral route, right? It is going to be the oral route. And the last question, what is the radiation that it is going to emit? It is going to emit both beta and the gamma rays. It is going to emit both beta as well as gamma rays. Clear? Now, it is the beta rays that are going to cause the destruction. It is the beta rays that is going to cause the destruction of the gland per se. So, age less than 45 years, it is going to be surgery. Age more than 45 years, it is going to be the radioactive iodine. It is going to be radioactive iodine. Just give me a second, guys. Hold on for a second. There's some issue with the mic. Now it is, I think it is settled. Okay. So age less than 45, we'll go ahead with total thyroidectomy. Age more than 45, we are going to go ahead with radioactive iodine. That is iodine 131 is going to be taken into consideration. Okay. So this is how you're going to manage your patients of the Graves' disease. The third thing that you should not forget in Graves' disease is take the patient for post-operative. It is post-operative. It is post-operative lifelong thyroxine. It is a post-operative lifelong thyroxine because you have removed the entire gland. You cannot afford not to give the patient with thyroxine. You have to put a lifelong thyroxine. So post-operative lifelong thyroxine has to be given. A post-operative lifelong thyroxine has to be given. So, in a quick nutshell, we have discussed the entire Graves' disease. It's an autoimmune disorder. It presents to you early. It presents to you a generalized or diffuse enlargement of the gland. That presents to you with toxic symptoms with gland, which is going to be enlarged. It will have same features as goiter as well. We evaluated that how you're going to diagnose goiter. That is your diffuse toxic goiter or Graves' disease. You know what are the thyroid and the extra thyroid manifestations. We know how to go ahead and manage it. There is a stepwise management protocol that we have discussed. Start the patient on anti-thyroid drugs. Wait if you're using a Carbimazole for around 8 to 12 weeks. Get the patient euthyroid. Once the patient becomes euthyroid, then you take the patient for surgery. Now, if it is less than 45, you go with total thyroidectomy. More than 45 years, you can go ahead with radioactive iodine. Okay. So this is all in all that you should know in the context of Graves' disease. So I hope we have been fairly, clarified and clear on what we wanted to talk about it. Right? Chalo. Everybody's clear until Graves' disease? Can we move on? Okay. So we'll talk about the next topic. That is going to be the toxic multinodular goiter. We talk about the toxic multinodular goiter. This is toxic multinodular goiter. Now, when you talk about the toxic multinodular goiter, to understand this, the synonyms that we are going to call, the nicknames for the toxic multinodular goiter, number one, we call it as the Plummer's disease. We call this as the Plummer's disease. Another thing that we are going to call this, we will call this as secondary thyrotoxicosis. So we have Plummer's disease and then you have the secondary thyrotoxicosis. All my friends who are listening, please do not get confused with a similar sounding disease which is called as the Plummer's syndrome, which is also called as the Plummer-Vinson syndrome. So a Plummer's disease is a toxic multinodular goiter, but when you talk about the Plummer-Vinson syndrome, when we call it as the Plummer-Vinson syndrome, which is also commonly referred to as the Patterson-Kelly syndrome. This is also called as the Patterson. This is also referred to as the Patterson-Kelly syndrome. also referred to as the Patterson-Kelly syndrome. So we have the Plummer-Vinson syndrome and the Patterson-Kelly syndrome. Now, what are the components that you have in this? In a Plummer-Vinson syndrome, you will have a patient with iron deficiency anemia called as sideropenic anemia. Along with that, there is atrophic glossitis. There's atrophic glossitis. There is an upper esophageal web which will cause dysphagia. There's an upper esophageal web. It is associated with visceromegaly. It is associated with visceromegaly and a nail deformity that is koinonchia. Right? So you have the iron deficiency anemia, atrophic glossitis, upper esophageal web, visceromegaly, koinonchia. This is your Plummer-Vinson syndrome. What we are talking about is a Plummer's disease. There are two different entirely subsets. They don't have any relation. Just because their name is Plummer's, that does not mean they're relative. No. Plummer-Vinson syndrome is different and Plummer's disease is different. Now, we have used the word here which is called as the secondary thyrotoxicosis. Now, if you remember in Graves' disease, I told you it's a primary thyrotoxicosis. Now, how did we determine it's a primary thyrotoxicosis? There you have the symptoms of toxicosis arrive first and then the swelling will arise. On the other hand, in a secondary thyrotoxicosis, you will see there is presence of thyroid swelling. There will be a pre-existing thyroid swelling. There is a pre-existing thyroid swelling, and this pre-existing thyroid swelling, the pre-existing thyroid swelling will be followed by the signs and symptoms. Will be signs and symptoms of thyrotoxicosis. With signs and symptoms of the thyrotoxicosis. With signs and symptoms of the thyrotoxicosis. तो अगर swelling पहले आया उसके बाद symptoms of toxicosis आए उसको secondary बोलोगे, लेकिन symptoms of toxicosis पहले आया swelling बाद में आया उसको आप primary बोलोगे. So primary thyrotoxicosis will have toxicosis first followed by swelling. Second thyrotoxicosis will have swelling first followed by symptoms. It will be followed by symptoms, right? So this is in the context of secondary thyrotoxicosis. Now, what is the cause? What is the cause for this? It is basically idiopathic. It is idiopathic. It is also seen in 30% of the patients who have long standing, who have this long standing untreated goiter. A long standing untreated goiter can suddenly transform into a thyrotoxicosis status, and that is what we call it as the toxic multinodular goiter. Now, very interesting thing that we found, that if you look at this as a representation of the thyroid gland, let's say this is a representation of the thyroid gland. We have uniform or number of follicles which are present, were quite uniform throughout the gland. So I'm just giving an example of this. Then we found that this gland is going to become into a nodular component. So you have the multinodular goiter. So your multiple nodules are present. Wherever you see there's a differential growth, we have decided or we have seen that differential growth is because of over proliferation. That is, whichever is active, they are able to proliferate. Whichever dormant, they are not able to proliferate. Whichever is active, they are able to proliferate, and whichever they are not active, they are not able to proliferate. Hence, the differential growth is formed. And that differential growth is now resulting in nodular status. It has been found that the follicles which are present between these nodules, let's say these are the overgrown nodules. So hence, because of this, I'm just giving an example, whichever has got an excessive growth. Now these are the one which are responsible for development of the nodular status. Hence, this is what we call it as the multinodular goiter. So initially it was normal gland, then it has become into a multinodular gland. If it is not treated, we don't know the exact reason, but the follicles which are present between these nodules, they become overactive. Why do they become overactive? That is beyond our understanding. We do not know exactly, but internodular follicular tissue. That is the word that we are going to use. We are going to tell you that internodular follicular tissue or the internodular follicular cells become overactive. They become overactive. Now, because they become overactive, they will now produce more amount of T3 and T4, and this excessive production of T3, T4 is now going to present to you with hyperthyroid status. So patient already had, if you look at this representation, we already have an enlarged gland. This is your multinodular goiter. These cells which are present, or the follicular cells which are present between the nodules, they become overactive now. These internodular follicular cells, they were not excessively active. They're not completely dormant also, they're there. But suddenly when they become overactive, they will produce more amount of T3, T4. When they produce more amount of T3, T4, it will become into an hyperthyroid state, and patient per se goes into hyperthyroidism. Okay? So this is how your Plummer's disease patient is going to become toxic. So how does the patient present to you? Now when we talk about the Plummer's disease, we have seen that it is seen in patients above 50 years, and these are also usually females when compared to males. How does a patient of Plummer's disease will present to you? So when you talk about the clinical presentation, quite predictable and understandable. How will a patient present down to us, right? The clinical presentation would be of a similar pattern. You will see patient is going to have signs and symptoms of multinodular goiter. Now, if you want to know what are the signs and symptoms of multinodular goiter, you have to refer back to our goiter wala lecture we did a few days ago. Just go down there, look how a patient of goiter presents to you. Same features will be here, will be there. Along with this, the patient will also have the signs and symptoms of hyperthyroidism. So patient will have symptoms of goiter. Along with that, there will be presence of hyperthyroid status as well. Now, if they ask you predominantly what are the symptoms, remember in Plummer's disease, the most common system involved due to hyperthyroidism, due to hyperthyroidism, it is going to be cardiovascular system. So you will see these patients will have more of CVS manifestations. As in Graves, we spoke that they have more of CNS manifestations. Here you would see there will be more of CVS manifestations. That is a cardiovascular manifestations would be noticed, right? Now again, I would like to evaluate this patient. So in terms of investigation, our protocols are very strict. So the first thing that I'm going to do is to do a thyroid function test. Now in the thyroid function test, what are you going to look for? You're going to look for T3, you're going to look for T4, and you're going to look for TSH. Because of excessive secretion of T3, T4, you will see these are going to be high, and TSH is going to come low because of negative feedback as expected. So I know it is a hyperthyroid status. Then I will do an ultrasound of the gland. Now in an ultrasound of the gland, I know it is having a multiple nodules. It will have multiple nodules. So now you have a hyperthyroid picture. You have a hyperthyroid picture with multiple nodules, right? If it was uniform, I would have thought in terms of Graves' disease. Now, if it is nodular, I'll think in terms of Plummer's disease. So I have done the TFT, I've done the ultrasound. I will also do a radioactive iodine scan. Again, I'll use the isotope iodine 123, oral route administration. Now here you will notice, now it is going to be quite interesting for us to understand that what is going to be the picture that you will see in your, what is the picture that we are going to see in toxic multinodular goiter. So you will notice that uniformly when you have initial picture, this is how the normal gland uptake will be there. You will see the entire gland is going to have a uniform uptake. This is a normal uptake that we expect. This is a normal uptake of the radioactive iodine on a gamma camera that we're going to expect, right? Now, if you have a patient who's having a toxic multinodular goiter. So in a toxic multinodular goiter, there will be areas where it will have nodular status. You remember I told you hemorrhage, the core gets fibrotic. So there are certain areas which are renderous, they're inactive, right? So let's say those are these areas which are inactive. So this will not have any uptake. So inactive area, let's say this is one inactive area, this is one inactive area, this is one inactive area, you will have no uptake, right? Whereas whichever is the active area is there, they are able to produce more amount. So you will see there is more uptake of the gland in a certain area, and there's no uptake of the radioactive iodine in certain area. So this area, patchy uptake, where either you have a very high uptake or you have no uptake at all, indicates it is your toxic multinodular goiter. So either you're having a very high uptake, that is indicating like a hot nodule or a hot uptake, or you are having no uptake at all. So the areas which are marked in this blue areas, no, or this circle, these are the nodular areas which are becoming dormant or become damaged. So these areas don't have any uptake. The rest of the areas are very high uptake compared to this. This is a normal, this is a very high uptake, but not uniform. This is a patchy uptake. Few areas do not have any uptake. Few areas they have a very high uptake. This patchy uptake indicates it is your toxic multinodular goiter. It is your toxic multinodular goiter. As simple as that, right? Now, once you have diagnosed, you have a patient with a toxic multinodular goiter, the management is going to be same. You have the first line management. We have just discussed it. The first line management, start the patient on anti-thyroid drugs. Start the patient on anti-thyroid drugs. That is the first thing. We've already discussed what is the protocol like. Once it is done, the second line is going to be intervention. So here it does not matter if the patient is age less than 45 years or age more than 45 years. The reason I'll tell you later, but now remember both of them will be surgery, and surgery depends upon what is the component of gland which is involved. Now, if there is only one lobe, that is unilateral lobe, or it is involving both the lobes if they're involved, right? If it is a single lobe involvement and the nodular status is coming from that particular gland, it is advised to go ahead with lobectomy, which we have already discussed it. If both the lobes are involved, then we have to go ahead with total thyroidectomy. Then we have to go with total thyroidectomy. Whenever we go do a total thyroidectomy, we have discussed it, this patient will get a lifelong thyroxine. This patient is going to get a lifelong thyroxine. As simple as that, right? So it's a single, it is lobectomy. If it is both, then the patient is going to get a lifelong thyroxine. As simple as that, right? So this is how you will manage your patients of toxic multinodular goiter. Okay. In the same context, we have another disease which is called as the toxic adenoma. We have another disease which is called as the toxic adenoma. So we'll talk about the toxic adenoma. Now, toxic adenoma is a condition which is an autonomous adenoma. It is an autonomous adenoma. Now, why do we call it as an autonomous adenoma is, you see every single follicle that is present, these follicles have a lot of T3, T4 that is present and in the reserve form. Even though they have a lot of T3, T4, they will only release the hormone. They will only release the hormone once the TSH is going to come and bind. So let's say this is the TSH hormone that is present. When the TSH hormone makes its journey and attaches to the TSH receptor, it is going to activate the TSH receptor. Once it activates the TSH receptor, it is now going to release the T3, T4. This is a normal phenomena that is occurring. In a toxic adenoma, he says, get lost. I am not going to, because I do all the hard work, I am not going to listen to the TSH hormone. Like it's like Pushpa style, jhukega nahi sala, that is the same component, right? So what it does is, it will say the thyroid follicle to make hormone. When the hormone is produced, it is independent. So whenever this nodule, it is going to form hormones. First of all, the TSH receptor on these nodules don't exist. Second, whenever the hormone is produced, it does not wait for the TSH hormone to come and tell whether to release or not. There is an active release. There is an active release of T3 and T4, and this is independent. This is independent of TSH. So it does not rely on the hormone. So it's like the hormone is formed, it is released. The hormone is produced, it is released. It does not care whether the body needs or not, hence resulting in hyperthyroid status. So it's an autonomous adenoma. Autonomous adenoma basically means it is TSH independent. This is basically a TSH independent nodule. It's a TSH independent nodule. So when you look at their presentation, again you will see these are relatively seen in young females. Toxic adenomas are seen in young females. Usually you will see between 20 to 30 years. You will see 20 to 30 years. Now their clinical presentation would be presence of solitary, this is a solitary thyroid nodule-like presentation. So this solitary thyroid nodule-like presentation, we have already discussed the presentation in thyroglossal duct cyst. So isolated nodule present in the midline of the neck that moves upwards with deglutination. Everything else is going to be in the same context. Apart from that, what else will you find? You will see there will be signs and symptoms of thyrotoxicosis. There will be signs and symptoms of thyrotoxicosis, right? Now, one new update that we have from the toxic adenoma. What is the new update that we have? The new update that we have in a toxic adenoma, that they are known to now have, they are associated with the somatic mutation. Now, this mutation obviously will be in the receptor. That is why they are not able to pre-exist, or they are not able to express it across. So this somatic mutation is seen in the TSH receptor gene. So this mutation is seen in the TSH receptor gene, right? Now, how will you evaluate? Again, it is going to be in the same context. So in terms of evaluation, investigation, everything, we follow the same protocol. The first investigation would be of thyroid function test, where you will see the T3, T4 and TSH. Needless to tell you, it is an autonomous adenoma, so you will notice there will be increased production of T3 and T4. Negative feedback will cause decrease in TSH. I know it's a hyperthyroid status. Second, I am going to do an ultrasound. Ultrasound, you will see usually presence of an isolated nodule, the single nodule in the thyroid gland. The third thing, you will do a radioactive iodine. In the radioactive iodine, you will see the entire radioactive iodine, whichever iodine that you give. No. Now, because this nodule is so active, because it's so aggressively active, that it will take up all the radioactive iodine that you give, it won't allow the rest of the gland. It competes for the iodine so high that whatever little amount of iodine that you give to look, no, that entire iodine is going to be sucked. It is going to be pulled by this nodule, and this is going to present to you as a hot nodule. This is going to present to us like a hot nodule, right? So this gives me a diagnosis that the patient is having a toxic adenoma. Management again remains in the same context. The first line of management, make the patient euthyroid prior to surgery. Start the patient on anti-thyroid drugs. We have discussed in detail about the anti-thyroid drugs in the Graves' disease. Go back to that section and review it again. Hi BDS Ayush, welcome. Now you have the second line. Once you make the patient euthyroid, the second line management is going to be surgery. So here we will perform only lobectomy, because only that side of the lobe is affected. Now once you have done with this, most of the patients do resolve. You don't need to worry about in this context, right? So this is how you will address the patients of your toxic thyroid swelling. Let it be the Graves' disease, let it be the Plummer's disease, or the autonomous adenoma. Every single context we have dealt. We have started our discussion from the Graves' disease. We told you the journey about the Graves' disease as well. So we spoke about the Graves' disease. We told that how are these antibodies, right? How is the antibodies in the Graves are going to behave? How is the gland getting enlarged? What are the reasons? What are the symptoms? What are the anti-thyroid drugs that we have? Then we spoke about the treatment protocol. We spoke about how the Carbimazole has to be given. Then we talk about the management. Then we have the Plummer's disease and the toxic adenoma. Is everybody clear with every single concept that we have given in toxic thyroid swellings? A quick feedback, guys. Fatawat. Are you guys clear? Mansoor, Rahul, Osama, you guys still there? Can we continue? शुरू करें? ठीक है. If you're clear, we are going to give a small comparative data. So this table will give you a comparative data for all the three disorders. We'll do a quick fill up and then we will try to do a recap as well. ठीक है, तो थोड़ा फटाफट रिविजन भी कर लेते हैं, है ना. तो क्वेश्चन नंबर 1, जो primary thyrotoxicosis, that is your diffuse toxic goiter, this we have learned with the example of Graves' disease. Toxic multinodular goiter we have learned with the example of Plummer's disease, and toxic adenoma is the autonomous adenoma. So what is the pathophysiology? When you talk about the Graves' disease, it is autoimmune. It is autoimmune and this is associated with lax antibody. Toxic multinodular goiter is actually idiopathic, or it can also be secondary to long-standing goiter. Autonomous adenoma, it is predominantly an idiopathic condition. It is predominantly an idiopathic condition. Okay. Now, when we talk about the age of presentation, Graves' disease we have seen in around 3rd decade of life. This is seen in age above 50 years. This is between 20 to 30 years. Needless to tell you that all these disorders are more common in female. All these disorders are more common in female. So what is the clinical presentation of Graves' disease? So here patient will have signs and symptoms of toxicosis. There will be signs and symptoms of toxicosis. This will arrive first. The patient will have signs and symptoms of toxicosis that arrives first, and this will be followed by goiter. This will be followed by signs and symptoms of goiter. So this is your Graves' disease. When it comes down to Plummer's disease, here the patient will have signs and symptoms of goiter first. There will be signs and symptoms of the goiter first. Then it will be followed by the signs and symptoms of toxicosis. It will be signs and symptoms of toxicosis. If you have a toxic adenoma, the toxic adenoma patient will present to you with solitary thyroid nodule-like presentation. This is a solitary thyroid nodule-like presentation with signs and symptoms of toxicosis. With signs and symptoms of toxicosis. As simple as this. Okay? So you have a quick component of what is the pathophysiology, age of presentation, clinical presentation with the sex determination. We have all these components which are present. Now, how is the skin over the swelling? How do you know that? The skin over the swelling, it is going to be warm because of increased vascularity. The other two, you will see the skin over the swelling will be normal as surrounding. The surface here is going to be smooth because there are no nodules. This will be having a nodular surface and this will also have a nodular surface. The most common system involved in Graves is CNS. Here it is CVS. Toxic adenoma does not have any specific system that is going to be involved. The extra thyroid manifestation that you will see in your Graves' disease. So you have the eggs of thalamus. You have the eggs of thalamus. Then you have the eggs of thalamus is nothing but Graves' ophthalmopathy. This eggs of thalamus is nothing but the Graves' ophthalmopathy. This is your Graves' ophthalmopathy. So you have the exophthalmos, which is your Graves' ophthalmopathy. Along with that, you will have the thyroid acropathy. The thyroid acropathy is formation of new bones that you will see. Then you will have the Graves' dermopathy. There's a Graves' dermopathy. It is also associated with gynecomastia. So we have the exophthalmos, you have the thyroid acropathy, there's a Graves' disease as well as the gynecomastia. These are extra thyroid manifestation. We do not have specific extra thyroid manifestation for the other two components. Investigation, we have already dealt with. What are the investigations that you're going to do? The first one is always a thyroid function test. Then you'll do an ultrasound and follow that up with radioactive iodine scan with iodine 123. This is what we follow for all three disorders. The first line management, start the patient on anti-thyroid drugs. Start the patient on anti-thyroid drugs. This is going to be same. And definitive management, age less than 45 years, age more than 45 years. Age less than 45, it is going to be surgery in all of them. Age more than 45, I will be using a radioactive iodine ablation with iodine 131. Here surgery. Toxic adenoma also radioactive iodine with iodine 131 in age above 40 years. Okay. Now if you look at the beauty of this comparative table that we have done, no, the entire lecture that we did in 1.5 hours. So yesterday we had a half an hour lecture on the Graves' disease, and then we continued from thereafter. And 1.5 hours of lecture, I have summarized this in hardly under 2 minutes. The maximum that we took was 2 minutes to summarize every single component, and all my bachas who are preparing for the competitive exams, let it be NEET PG, INICET, this is your go-to table. So this is how we'll summarize every single topic that we read. So once we have done a detailed elaboration, we will concise it into a more revisable form. So did you all understand the whole concept of the toxic thyroid swellings? If you're done, this is your radioactive isotope scans that we have. Now nothing spectacular about it. So when you look across here, so when you look across here, in this is the gland that we have. This is the entire gland. This is the thyroid gland. This is the uptake. This is this area where there is very little uptake when compared to surroundings. So wherever you have a lesser uptake, it is going to be a cold nodule. Okay. Now here you say in the entire component, the gland is having a very little uptake, but this area is having a very high uptake. So this is going to be our hot nodule. Okay. So this is something that we understand quite clear. Now, if the entire gland is not visualized, only the nodule is visualized. That means it is so hungry that it is eaten away all the entire thyroid hormone that you have given. So this is your autonomous nodule, or also called as the toxic adenoma. Here you see, this is the gland that we have. Let's say this is the orientation of the gland. These are the areas where you have lesser uptakes. You see, these are the areas where you have the lesser uptake, and you see this is the area with a very high uptake. So this is either there is a very high uptake or there is no uptake or low uptake. That indicates there are differential areas. So areas which are active is going to get more hormone, and areas which are not active, they're becoming cold. So this is your toxic multinodular goitre, a very, very classical picture that you're going to see. If you're not able to recognize, if the entire gland is damaged, you see very little uptake throughout the gland. This is a picture of thyroiditis, and that is going to be our discussion for the next topic. So this is how the interpretation of your radioactive iodine scan is going to look like. Sorry. Now, if you have any questions, any queries about the toxic thyroid swellings, I am here for you. Go ahead and ask. Otherwise, that is it for today. Thank you so much for joining. If you have any questions, you know where to find us, right? Any questions, any queries, you can tune in down to the Instagram channel that we have, to the surgery guy. So this is our Instagram, this is our Telegram. So any questions, any query that you have, you can tune it down to here, and then we can answer there as well. Types of thyroidectomy, beta, we have a beautiful lecture on that. It is going to come up in the next week, where we'll talk about the thyroid surgeries. as promised in BLS, I will give you all the clinical component also. I will give you my own surgical videos. We will go through that entire surgery step by step, from incision to the delivery of the gland. We'll talk about the dissection. We'll talk about looping, every single thing. An aspirin, beta hemi, half is preserved, all that. Again, don't worry about it. We have a pure lecture only on thyroid surgeries. We'll explain you in detail that when we say lobectomy, it is lobe for isthmus. When we say total lobectomy, only lobe is removed. The word hemithyroidectomy currently does not exist. It is abolished. Either we use lobectomy or total lobectomy or total thyroidectomy. Okay? So, if you have no other questions, thank you so much. Signing off for today. We'll see you next week. Again, there's a surprise. Tomorrow we might have a lecture, and it is going to be a grand session. As we have done last week also, we're planning for doing that as well. I'll post that in the Instagram channel. Do look up there. So all the updates will be there on a daily basis. By afternoon, you will know whether we have a session or not. If you're having it, it is going to be a grand session again on our thyroid component. With that, thank you so much. Good day. See you guys again. Bye-bye.